Students, this video is continues from the last video, organophosphorus compounds. So in the last video, we discussed about what is organophosphorus compounds, what are the examples of organophosphorus compound, generally how organophosphorus compound toxicity occur, okay, either acute poisoning or chronic poisoning. So what are the chances for getting acute poisoning or chronic poisoning? So next, what are the different types of organophosphorus compounds? So how this organophosphorus compound produce toxic effect mechanism? So later on, manifestations of organophosphorus compounds, okay, muscarinic, nicotinic, central actions. Okay, next is next manifestations are neurological manifestations. Okay, later on we discuss about how to diagnose the poison mainly occurred with organophosphorus based upon the clinical symptoms, based upon the levels of pseudocholinesterase enzyme activity in the blood. So next, based upon the mm, based upon the anticholinergic effect after administration of atropine. Okay, next is based upon the chemical analysis. Okay, now today this video we are going to discuss about how to manage the organophosphorus compounds. Okay, so organophosphorus compounds poisoning generally occur either ingestion or maybe inhalations. So the organophosphorus compounds, they are highly lipid soluble. They have the capacity to enter into system circulation through any means. By even after coming contact with the skin, they are able to absorb quickly into system circulation. Even they are able to absorb through inhalation through lungs. Even they are and they quickly absorbed through oral route also. Okay, by any means of route of administration, they are quickly absorbed into system circulation because of their highly lipid soluble. So that immediately you can do decontaminations, and you have to maintain the supportive therapy. How to do decontamination? Decontamination is nothing but early decontamination. It prevent the early exposure to major exposure. Okay, this you have to do by uh, immediately after poisoning with organophosphorus compounds. You can remove the contaminated clothes. Okay, whatever the cloth which is contaminated with organophosphorus poisoning, immediately you have to remove the clothes. Okay, because the contaminated clothes may have the chances for exposure of organophosphorus compounds systemically. Okay, so immediately remove the contaminated cloth. So later on, okay, immediately you washed the person is have to wash it with sufficient amount of water and soap. Okay, especially in skin folds, underside fingernails, long hairs require particular attentions. Suppose if it is the contamination happen in the eye, you have to wash the eye with water or normal saline. Okay, so this is about the immediately you have to do decontamination nothing but you have to immediately remove the contaminated skin, contaminated surface with organophosphorus compounds by removing cloths and as well as washing the person with a sufficient amount of water and soap. If things happen in the eye, immediately you have to do ocular decontamination by washing eyes with sufficient amount of water and normal water. So next, immediately you provide the supportive therapy. Okay, immediately if the patient is comatose and vomiting, patients should be asked not asked, should be kept the patient in left lateral position with preferably head down position. Okay, so this will reduce the risk of aspiration of vomiters. Okay, and facilitate the respiration. Okay, so next, then immediately you have to suck. Okay, in intubation, patient airway should be secured with placement of airway and with enterotracheal intubation, especially if the patient is unconscious and having seizures. Okay, so if you keep the patient left side and preferably head down position with neck extension to reduce the risk of aspiration and also maintain the airway. Okay, and also it is used for doing enterotracheal intubations. Okay, so in between, frequently you have to do sucking. Okay, any excess oropharyngeal respiratory secretion. Generally, acetylcholine increase the secretions in the throat and as a respiration. Okay, if you not remove that secretion, it may block the respiration, so difficult providing the respiration. So immediately you have to removing of excessive oropharyngeal and respiratory secretion in order to prevent the occlude the airway. Okay, then immediately you have to provide the respiration provide the respiration by giving oxygen. Okay, oxygen. This is the thing immediate, and you have to maintain the circulation also. So this is the first you have to do. Okay, decontamination is a process by which you have to remove the contaminated clothes, and as well as you have to remove the poisonous from the surface of the body by washing the patient with water and early decontamination of eye with again with water. So later on you have supportive therapy. Immediately the patient is keeping some specific position. By this way the patient able to take breath easily and maintain the airway clearly. Okay, so frequently you have to remove the any secretion from the respiratory tract, and if possible to provide the respiration. Okay, by giving oxygen. So next is gastric lavage. Okay, second process is gastric lavage. Already the gastric lavage you discussed in the general principles of the you have to do within 1 to 2 hours of the injection of poisoning. Generally complication generally there, like aspirational pneumonia, hypoxia, laryngeal spasm. Because gastric lavage you have to do by inserting of the orogastric tube, generally they cause throat spasm. Okay, next is activated charcoal. Okay, so this activated charcoal administration reduce the poison absorption. Okay, next single dose to multiple dose activated charcoal generally routinely used in clinical practice. 25 grams every 2 hours. Okay, avoid the catharatics and induce emesis. Okay, so there is a induction of emesis is contraindicated in organophosphorus combo, because emesis causes expulsion of the this organophosphorus content, okay, from the stomach. Again it leads to aspirational pneumonia and further excessive toxification. So then you have to avoid the induction of emesis and administration of cathartic. So you can use activated charcoal. Okay, gastric lavage and activated charcoal. So next is antidote. So what you have to treatment process: decontamination, supportive therapy. So mm, next is gastric lavage and activated charcoal. Later on you have to give antidote. Okay, two type of antidote generally you observed here. um, Specific antidote for muscarinic effect. Okay, so anti atropine. Okay, atropine is a specific antidote of muscarinic but not effect on the nicotine action. So it refers the life threatening feature that can result into death, like respiratory paralysis, bronchospasm, excessive bronchoconstriction, bronchosecretion, and severe bradycardia hypotension. So nicotinic so atropine mainly block the muscarinic actions associated with acetylcholine. Especially life-threatening features will be reversed, especially respiratory failure, bronchospasm, excessive bronchosecretion, and severe bradycardia hypotension. Okay, there is a some dose is there. Okay, so in single injection you can administer 2 to 5 mg atropine every 10 to 15 minutes, um, or otherwise you continuously infusion 1 mg per mg till full atropinization. Okay, so continuous IV infusion, or we have to bolusing. Continuous till atropinization is nothing but if the patient is observed with any one of the targeted atropine treatment, you can stop the atropine. Okay, so when So when you continuously you have to administer the atropine, so until the complete atropenization. So what is meant by atropenization? Suppose if you see these endpoints of atropine therapy, if heart rate is increased more than 80, okay, dilated people, dryness of mouth, increase in blood pressure, okay, so then is considered targeted endpoints for atropine therapy. Okay, so once they reach, you can stop the atropine treatment. Okay, so recommended dose is 1.8 to 3 mg with subsequent doses doubled every 5 minutes if there is no response. Okay, or repeat the same dose until the atropine is reached. Okay, maintenance dose. Okay, 20% of initial atropine dose per hour for 24 hours. Gradually taper over 5 to 10 days continuously. Okay, so monitor the adequate therapy. Okay, initially you have to administer 20% initial atropination dose per hour for 48 hours. Gradually you have to decrease the dose, so over 5 to 10 days. Okay, so this is about atropine treatment. Okay, next. Next, second drug, second antidote is oxims. Okay, what is oxim? Oxims are reverse of cholinesterase enzyme. Okay, so they reverse the activity of cholinesterase enzyme function. Okay, reback the cholinesterase enzyme activity. Okay, previously cholinesterase enzyme is going to be inhibited by organophosphorus compound. By the administration of oxims, just simply they reactivate the acetylcholinesterase enzyme. So once you reactivate the reactivated acetylcholine, immediately will immediately break down the whatever the accumulated acetylcholine at the muscarinic and nicotinic sites, so which aid to decrease the manifestations of organophosphorus compounds. Okay. So oxims, okay, mechanism of actions. Uh, so maxims are generally useful if you administered within short span of time. Okay, if you take more time, so because of the enzyme organophosphorus complex aging, aged enzyme cannot be no longer be reactivated by oximes. Okay, so if the patient if the time is more, okay, between the injection and as well as the administration oxim, the functioning, okay, the efficacy of oxims will be doubtful. Okay, so how oxims they reactivate the acetylcholinesterase. So how atropine will reverse the manifestations of organophosphorus compound? Already you know that it is a reverse. It is a competitively inhibit the muscarinic receptors. So especially it will antagonize the muscarinic actions of acetylcholine. So how these oxims were going to be works? How they are going to reactivate the acetylcholinesterase? So oxims get attached to free anionic site of the enzyme. Okay, organophosphorus compounds they bind only estratic site present on the acetylcholinesterase enzyme. They won't bind anionic site. Okay, one side is free, one side is blocked by organophosphorus compounds. So these oxims first they get attached to the free anionic site. Later on, okay, they immediately they interact with phosphorus atom of the organophosphorus compounds. Okay, immediately they bind with phosphorus atom of the organophosphorus compound that is attached to the estratic side. So immediately this oxims phosphate complex is forms. Okay, so oxims, okay, immediately they bind with the phosphate atom of the organophosphorus compound, so that they form oxims phosphate, okay, complex. So immediately the enzyme is free from the organophosphorus compounds. Okay, so like this you can reactivate the organophosphorus, reactivate the acetylcholinesterase enzyme. Okay, so again I will tell you oxims first they bind with anionic site present on the acetylcholinesterase enzyme. Later on, immediately they get interacting with the phosphorus atom of the organophosphorus compound that is attached with the ester side. So with this, they form oxims and phosphate. Okay, right? Oxims and phosphate complex. Okay, so the phosphorus atom of the organophosphorus compound, instead of interacting with the ester side present on the ester enzyme, they can interact with the oxim. They form oxim phosphate complex is formed. Okay, immediately the free enzyme is released. Okay, So the WHO recommends some doses, okay, 30 mg per kg single IV injection, and 20 over 20 to 30 minutes, followed by continuous infusion 80 mg per kg per hour, okay, until recovery. Okay, 12 hours after atropine has been stopped. Okay, right. This is about the some recommended dose. Okay, still side effects of oxyms also can observe like dizziness, headache, blurred vision, okay, and diplopia. Okay, so this is about thing. So suppose how you are going to be correct the cardiovascular complications like hypertension, bradycardia, okay, severe hypertension benefited from the giving of vasopressor agents. Next, mm, next respiratory complications. Respiratory complications. So you have to complication avoided by giving oxygen. Okay. Next, CNS complications, especially CNS complications of organophosphorus is seen as in the form of convulsions. So the convulsions are antagonized by giving diazepam. Okay, slowly 10 mg slowly, which can repeat at 30 to 40 mg 24 hours. Okay, so again you have to give antibiotic prophylaxis to prevent the risk of infections. Okay, so next is furosemide. Okay, in order to prevent the pulmonary edema. Okay, magnesium sulfate. Okay, it reduce release of acetylcholine from the presynaptic terminal. Okay, next clonidine. It may reduce the synthesis and release of acetylcholine. These are all supportive drugs. Okay, this is about the treatment of. Later you can go for hemodialysis and hemofiltrations. Okay, so next, so what are the treatment for the organophosphorus compounds? Again I will tell the outline. So early decontamination and maintenance of supportive treatment, and administration of antidotes like atropine block the muscarinic actions of acetylcholine. Next, oxims, they are reactivator of acetylcholinesterase enzyme. They reactivate the acetylcholine enzyme. With this, there is a decrease both nicotinic action and muscarinic action. But atropine only block the muscarinic actions. They won't affect on the central nervous system effect associated with organophosphorus compounds. Next, you correct the metabolic some alterations like respiratory problem and cardiovascular problem, okay, and all. Next, prevention of infection, give infections, and other management of other complications. Okay, so this is about management of organophosphorus compounds. So this is very important for examination. So it is very poisonous treatments are very easy. Please go through all poisonous. Okay, you can write very easily. So with this I complete organophosphorus compounds poisoning.